Hello everyone, my today's lesson is about gastroesophageal reflux disease. The content of this presentation includes definition and the pathophysiology, epidemiology and the natural history, clinical manifestation, differential diagnosis, management and the complications of gastroesophageal reflux disease. When we see the definition and the pathophysiology of gastroesophageal reflux disease, gastroesophageal reflux is involuntary passage of gastric contents into the esophagus, and it is physiologic condition. And the gastroesophageal reflux disease, a reflex associated with a mucosal damage or symptoms severe enough to impair a quality of life. Whereas regurgitation is a passage of refluxed gastric contents into the oral pharynx and the mouth, and also drooling out of the mouth. And vomiting is expulsion of the refluxed gastric contents from the mouth. Rumination is a voluntary, habitual regurgitation of ingested food that is subsequently spitted up or re-swallowed. There are three major tiers of defense which limit the degree of gastroesophageal reflux. This includes anti-reflex barrier, esophageal clearance, and esophageal mucosal resistance. Transient lower esophageal sphincter relaxation is the primary mechanism allowing reflux to occur, and gastric distension is the main stimulus for this transient lower esophageal sphincter relaxation. And this is a neural reflex which causes activation of intramural inhibitory neurons which release nitric oxide to relax the lower esophageal sphincter. Higher frequency, greater incidency, and higher acidity of the reflex during this relaxation predisposes for chronic esophagitis. Factors influencing gastric pressure volume dynamics and positions that places the gastroesophageal junction below the air fluid interfaces in the stomach can make reflux more likely. Regarding epidemiology in the natural history, daily regurgitation is present in around 50% of infants less than 3 months, and in greater than 66% at 4 months, and this is nearly complete resolution occurs by 2 years, whereas prevalence is from 1.8 to 8.2 among children and adolescents, and when it occurs among these age groups, 30 to 50% likely to persist to adulthood. Children with neuromuscular disorders and the Down syndrome are at increased risk for developing gastroesophageal reflux disease, and there is a genetic predisposition on gastroesophageal reflux disease. Regarding clinical manifestation, symptoms of gastroesophageal reflux disease vary with age. In infants, regurgitation and vomiting, hematemesis which predispose to anemia, food refusal and irritability, poor growth and the failure to thrive, and also apnea and stridor are the clinical manifestations. Whereas during preschool age, intermittent regurgitation and vomiting, respiratory complications, decreased food intake without other complaints, non-organic failure to thrive, and Sandifer syndrome can occur. In older children and adolescents, nausea, epigastric and diffuse abdominal discomfort and regurgitation, substernal squeezing and burning pain which radiates to the back and which resolves within a few minutes to hours, either spontaneously or with some medications, and usually after meals. It awakens patients from sleep, and it might be exacerbated by emotional stress. Regarding evaluation, the differential diagnosis in children who is having gastroesophageal reflux disease include cow milk allergy, eosinophilic esophagitis, infective esophagitis, cyclic vomiting syndrome, and hiatal hernia. And also achalasia can be a differential diagnosis for this disorder. Regarding investigation, the first is empiric treatment. Empiric treatment is by trial of acid suppression. This is a diagnostic as well as a therapeutic, and this is suggested for older children with uncomplicated heartburn. So if a patient responds to empiric time trial of acid suppression, it is a diagnostic as well as a therapeutic. The other is endoscopy and histology. This is to determine the presence and the severity of esophagitis and its complication, and to exclude other disorders. And it is indicated for children with hematemesis or epigastric or abdominal pain which is not responding to empiric treatment, and for children with recurrent regurgitation after 2 years of age, and if there is dysphagia and odonophagia. An esophagus that appears normal at endoscopy does not exclude the presence of gastroesophageal reflux disease. And sensitivity can be increased with a mucosal biopsies to histologically detect erosive esophagitis and eliminate other causes of esophagitis. Esophageal pH monitoring is the other imaging modalities. This is for assessment of the frequency and the duration of esophageal acid exposure, and it's indicated for assessing efficacy of acid suppression after treatment and evaluating atypical GERD presentation and in non-verbal children and infants with repeated apnea. The other investigation is barium contrast radiography. This is for patients with vomiting and dysphagia, and it is to evaluate for the possibility of anatomic abnormalities such as hiatal hernia, achalasia, esophageal stricture, or stenosis in the intestinal malrotation. So barium swallow is used to identify those things. The other is laryngotracheobronchoscopy. This is to see airway signs of extraesophageal gastroesophageal reflux disease. And this is used for diagnosis of silent aspiration by bronchoalveolar lavage and the quantification of lipid-laden microphage, and by detection of pepsin in a tracheal fluid. Regarding management of gastroesophageal reflux disease, the first is lifestyle changes, dietary modification to avoid reflux-inducing foods for children, and the normalization of feeding techniques, volumes, and also frequency in infancy, and avoiding the supine position soon after eating, especially for young ages, and the promotion of salivation and the head of bed elevation is very important. The other is pharmacological treatment. From this, proton pump inhibitors is the first. This reversibly binds to and inhibits the hydrogen potassium ATPase pump that resides in the luminal surface of parietal cell membrane. And there is different drugs in this group, and the difference in pharmacology and efficacy among drugs in this class appears to be small and clinically insignificant. The other is histamine type 2 receptor antagonists, or H2 receptor antagonists. This is mainly used for mild to moderate esophagitis, and it blocks histamine 2 receptor on the parietal cell. And in this case, tolerance might develop and limit efficacy for long-term management. Regarding efficacy, proton pump inhibitors are better than H2 receptor antagonists in relieving symptoms and healing esophagitis, and they have greater reduction in acid secretion and a longer duration of action, and also good tolerance, and that tolerance does not develop in the case of proton pump inhibitors, whereas tolerance is common in H2 receptor antagonists. And the safety concerns of chronic use of proton pump inhibitors include phenomena of acid rebound after discontinuation, and also the risk of having enteric infection, especially with Clostridium difficile. The other is antacids. This is used by neutralizing gastric pH and used for short-term relief of symptoms. And the preparation usually contain combination of magnesium and aluminum hydroxide, and the chronic use is generally not recommended. The other is prokinetics, which enhances esophageal peristalsis and increase lower esophageal sphincter tone, and they should be considered for use only in carefully selected patients, including those who have failed anti-secretory therapy and for whom quality of life is adversely affected by recurrent vomiting. And there are different drugs such as baclofen, metoclopramide, and betanicol, which can be used as treatment. The other is surface agents, which is rarely used. This form is a surface gel that creates a physical barrier against regurgitation of gastric contents and protects the esophageal mucosa. Two such substances have been evaluated in the treatment of GERD, including sodium alginate and sucralfate. The other treatment is surgery. This is indicated for recurrent pulmonary disease from aspiration of reflexed material, and also if the patient is having failure to thrive that does not respond to tube feeding, and if the patient is having interactable esophagitis and strictures that does not respond to proton pump inhibitor. Commonly performed operation is a Nissen duplication, but many modifications have been described, and if surgery is done after drug resistance gastroesophageal reflux disease, symptom improvement is seen in 60 to 90%, and the complications of anti-reflux surgery include breakdown of the wrap, infection, the perforation, and also persistent esophageal stricture. Regarding complications of gastroesophageal reflux disease, there are multiple complications. From this, the most common one is esophagitis, which occurs in 50 to 60%, and it manifests as irritability and feeding aversion in infantis and epigastric pain and hematemesis in children. And prolonged and severe esophagitis leads to distal esophageal stricture, which causes long-term metaplastic transformation. This is Barrett's esophagus, and it is a precursor of esophageal adenocarcinoma. So only 1.5 to 3% develop Barrett's esophagus. But once they develop Barrett's esophagus, that is a precursor of esophageal adenocarcinoma. The other complication of gastroesophageal reflux disease, the relations that have with asthma. And gastroesophageal reflux is a common disorder among patients with asthma, and it is an established trigger for asthma. There is a reciprocal relationship, and respiratory symptoms may also provoke gastroesophageal reflux. There are two mechanisms which is proposed whereby gastroesophageal reflux disease might produce bronchoconstriction. From this, during gastroesophageal reflux disease, there is an increased vagal tone which causes bronchoconstriction. It's called gastric asthma. And also during gastroesophageal reflux disease, there is a microaspiration of gastric contents which causes bronchoconstriction. In this case, the pertinent history that we should have to ask to know whether GERD is there in worsening or in triggering asthma include asthma symptoms during an episode of gastroesophageal reflux and use of an inhaler when feeling symptoms. And also nocturnal asthma is highly associated with the prevalence of or presence of gastroesophageal reflux disease in asthmatic patients. In about 60% of children with asthma and evidence of gastroesophageal reflux, asthma control will improve with treatment for reflux. And a 3-month trial of proton pump inhibitors are recommended in these patients. The other is apnea and the gastroesophageal reflux disease. Apnea and the acute life-threatening episodes due to reflexes owing to laryngospasm due to an abnormal intense protective reflex. And infants with such apnea are often positioned supine, and they are recently fed, and they show signs of obstructive apnea. And stridor, which is triggered by reflex, generally occurs in infants anatomically predisposed toward this stridor. The other complications include hoarseness, chronic cough, pharyngitis, sinusitis, otitis media can be present in a patient having gastroesophageal reflux disease. And dental erosions, esophagitis, and regurgitation may also induce failure to thrive, and the enteral or parenteral feeding might be required. Thank you for your attention, and don't forget to subscribe the channel.